Good morning, good afternoon, and good evening, our dear colleague. Another exciting MOH Connect event. I am Dr. Muhammad Omar Farouk. I'm a consultant vascular surgeon. I am delighted to be accompanied by two of the most eminent philippologists worldwide. And this time we're going to learn from their clinical experience about a topic which is very near to all our practice, which is ultrasound-guided sclerotherapy. Let me introduce my first speaker, which she doesn't need introduction. She's worldwide renowned international philipologist, Professor Erica Mendoza, and she is mainly have venous interest, specialized with duplex ultrasound. She has her own philosophy, strategy, and books in that field. She is one of the great advocate for Chiva procedure, and she's also was the General Secretary of the German Philipology Society. She's also have multiple workshops in Germany and of all international meeting. She is the General Secretary of German Society of Philipology since 2015. She played a great role both in COVID and post-COVID, and we're going to enjoy a live cases with her with a ultrasound-guided sclerotherapy. I have the second, the very eminent speaker, Joseph Grace, but I will leave if Professor Erica Mendoza is ready to start, because Professor Joseph is going to give us his pearl experience, quite astounding panelist with us today to tell us a lot of tips and tricks about this technique. So back to you, Erica. We can see your screen quite clear, but probably we need your voice.
That's a good point.
Okay, now we can hear you very well.
Last minute stress, I'm sorry, as always.
Don't worry, you're fantastic.
Now it's everything online. Okay, so let me start. Thank you again for this wonderful moderation, and thank you Sigvaris for doing this this event. This is obviously supported by Sigvaris. It could be a conflict of interest. Indications for ultrasound-informed sclerotherapy, I will make it very short in my eyes, and if you look at the current guideline of the European Society by Marianne de Mesener, which is gorgeous, you have some important indications for foam, ultrasound-guided foam sclerotherapy, which is the saphenous vein insufficiency, the recurrent veins after high ligation and stripping, perforating vein, and I added transtibial, as you will see in a case. If you are treating saphenous trunk incompetence with foam sclerotherapy, and we have to think about countries where they don't have the ability to go to surgical theaters just for treating saphenous veins sometimes, you may do it also with foam, but it is recommended to do it with a diameter less than 6 millimeters. And it is a pity that this is not said where the diameter should be 6 millimeters, because we know that at the groin, it is always larger than a medial thigh. But if you take it as an orientation, you might find your way. And which is changed after studies having been performed to that point, is that patients with superficial incompetence undergoing ultrasound-guided foam sclerotherapy, as I've always done it like this for all the patients, but here, especially for the saphenous trunk treatments, it is recommended to put post-procedural compression. And I think this is really important because I'm sure it reduces also the discoloration of the skin, which can appear after the treatment. And so I think this is a very good recommendation. This is, of course, repeating that if you do a treatment of foam sclerotherapy, you should use the ultrasound, and I think not only during, but also before. You need to make sure what you are treating. You have to make a plan. The patients we see today, they are already made the plan. I just will show you before doing it the key points, and then we go right ahead treating them. And what is the most important reason for me to treat ultrasound-guided foam sclerotherapy are patients with recurrent varicose vein, because going back to an already intervened region with scars and so on is much more hazard to the patient than if you give ultrasound-guided foam sclerotherapy. So this is just to see the skills, but not a learning course. If you want to learn, you have to be able to do a proper ultrasound, weeks and months of learning. You need to know how to handle foam and so on. But I just want to show you what is possible. It is always important to make the analysis of the patient and investigation. You need to decide about concentration of foam sclerotherapy agents and the diameters and the flow velocity. We will see that come to this point and help you deciding this. And then you have to manufacture the foam, and we are going, just please show my other camera, because I will show you how I do this in my office. Do you still hear me when I move? Just when I'm here, do you still hear me? Do you still hear me?
Yes, I can hear you.
Yes? Okay, thank you.
Yes, we can hear you very well.
And we are in this camera. You are seeing my hand moving, yes?
Yes.
You are seeing my hand?
Yes, we can.
Kannst du mal gucken hier? Yes, they see it. Is the light, is it better with this light or with this light?
Both are about the same, Erika.
About the same, okay, so.
Yep.
I have ready wrapped with everything I need inside. And this I open just sterile. This is of course for the presentation. I open it just in the moment of treating. They see it. Look there. They see. Look, we cannot see in the chat. We cannot see. Okay, people can't see me doing this, but I can see it. This. I can see it.
It is if you change the view in the Zoom, in order not just to view the slide, but to view the panelist, then the screen we're speaking about is from her mobile by the name of Erika Mendoza.
So I will switch off this microphone and put off the other one, because then automatically this automatically will put.
Okay.
Ja, das versuche ich ja gerade.
Can you share, our dear organizers, Mr. Khalid, the mobile phone to be shared the screen? Or it has to be done from the mobile phone? We can see you.
Perfect. Moving.
Yes.
Perfect. So
please go ahead.
We have inside a three-way connector.
Yes.
Obviously, you do it with gloves, but now for the demonstration, I don't. You have two large syringes and one little one, and my colleague hands me over an ampoule of 1% methoxysclerol. And thanks to Joseph Race visiting me, I now always use blunt needles, avoiding stickings. And
excellent.
I have 10 milliliters. I put 2 mils into 10. This means I have a concentration of 20%. I mean, one part liquid and 4 parts air. Then I put this together, and you can start doing it just in a completely open way. But the trick is, if you close it a little bit, yes. If you close it a little bit, then you will have a better foam performance, and then you will hear,
excellent, yes,
the noise performing the foam, and you see already the foam is there. And then
how many times do you need to do this?
Treatment, I take just little amounts of 2.5 or 2 mils, because the German guideline says you can't apply more than once 2 mils inside the patient. So just to avoid me to overdose, each time I make a puncture, I use this way to do it, and and then show here. Then the foam is quite good, as you see, and
Yes.
this also makes me manufacture the foam for every new puncture, and this makes me have good foams straight away, because if you would use the big one to inject,
Yes.
it would get spoiled in the time. What I want to show you, I think everybody knew this. Of course, I use little needles, and if I have spiders, I use less, the yellow ones. But now I want to show you something I learned from my friend Massimo Capelli, and this is, if you see it here, I have put 1 ml, yes, 1 ml of 3% ethoxysterol in 8 mils. In 8 mils, this is a little bit more. Yes, no, it's perfect. In 8 mils of air. The total is 8 mils, so I have 7:1, and this is the dry foam, because you have more air in relationship to only 1 milliliter. And if you make this short foam, you will see that I again use a little syringe to. You will see that it is far more solid. You can make amounts of it. You see, it is really hard. No, it went. This is a perfect foam to be used in large veins or next to the deep veins, because it advances very slowly. And we will use this also in our patients today. So this was my way of manufacturing. I think that this preparation with one package for everything I need is a ecological way of avoiding too many individual rods for opening. And yes, I go back to my camera.
It is excellent, Erika. Thank you. Do you have any comment to Joseph until she goes to?
Now I'm going to change a bit and give the mic to Joseph, because from Joseph Grace I learned a very interesting thing when I visited him in Australia, and this is that he performs the ultrasound guided sclerotherapy in large veins, adding perivascular
infiltrate.
Yeah. So let me take this opportunity.
Yes, he will tell you. He will tell you, and I will get changed and bring a patient in the room.
Brilliant.
Thank you.
So this gives me the pleasure of introducing one of the most eminent phlebologists worldwide from Australia, Professor Joseph Grace. He is a phlebologist and vascular interventionist. He's also senior lecturer, Faculty of Medicine, South Sydney. He has really a fascinating CV with a huge amount of activity and research and venous workshop and venous symposium and venous intervention. Currently, he is PhD candidate in research of physiochemical properties of medical adhesive and the human tissue interaction. Very exciting topic. He's also very well known for his papers on phlebology and fluid mechanics with the University of New South Wales. He's also have a lot of information about health care in the public sector, with a lot of ethical and a lot of exciting field in that field. He's going to squeeze to us his 20 years experience or even more in using sclerotherapy. So it is really a privilege to me to introduce Joseph to all of us, and we're eagerly waiting to hear you, Joseph.
Well, thank you very much, Professor Omar. I'd like to thank you for your kind invitation and kind words. In addition, Sigvaris has been tremendously supportive, and this MOH program is a testament to that. A kind gratitude to Mahmoud El Gadban. He's been the inceptor and has always kept us up to date. So, my dear colleagues, professors, doctors, and lifelong friends internationally, it's a pleasure to be joining you here in Sydney, or from Sydney. I thought I would first say thank you so much, Dr. Mendoza, for showing us your foam sclerotherapy production. I can't emphasize the importance of simplicity when looking at such a technically a complex procedure. It is so important to have your medications set up and ready to go. It's essential that we recall and understand that we're actually manufacturing a drug when we're using foam sclerotherapy. So by simply going from a solution to microbubbles, we have actually manufactured a new drug, and technically we still remain using this form as an off-label use. So do you use STS, or do you use ethoxysclerol? Do you use air? Do you use medical CO2 gas, oxygen, etc.? I think that is open and entirely available to preferences. Foam sclerotherapy since 1995. I would say with a high degree of certainty that it is essential that you develop a profile and that you actually keep your processes as simple as possible. Because remember, you'll see shortly when Dr. Erica commences the treatment, firstly, the patient needs to be worked up. Secondly, the procedure is being performed in the dark. And thirdly, you may or may not have the assistance. So thank you so much, Dr. Erica, for commencing with the single most important rules and facts, and that is production of foam. You need to have this efficient, simple, and reliable. And remember, we are actually using it off-label, so we can only rely on consensus statements, both the European, the American, and the Australian, and these guidelines are absolutely essential. We can talk for hours about sclerosant and concentration and whatnot, but for now, I'm going to hand back to you, Dr. Erica, if you're ready to go.
Yes, I'm ready to go. I have to share my screen because I have patient, and where is the nipple point? Hier das abgerissen, das ist an meinem T-Shirt, das T-Shirt nicht in der Kamera. Everything possible to be gone is gone. I lost the connection to my daughter's bringing it to me. So I share the screen with my ultrasound device. Yes.
Yes, we can see your ultrasound screen.
Okay, we do it without a name.
And we can see from your mobile the very kind patient that we like to thank her for.
But you see me also?
And we see you as well, yes.
Yes, and I have to change this, like this position. There was something missing. I'm getting older.
A real expert in live video streaming, Erica.
But I'm getting older every time.
Younger, I think.
We have a wonderful patient here, Miss Newton. Turn around there. More. And you see here you see here the varicose veins on the back of the leg. Can you please, perhaps with the camera, come here? And did you find no. Okay. You see the veins here on the back. And we now move the external camera to see better what we are doing. Drehen Sie sich nochmal zum Fenster hin. Here we see
Yes,
you
we
see
can
in
see
the
it
extra
now,
camera
yes.
the image. So this patient really has not recurrence or a complicated, oh, I found it, or a complicated situation of the deep veins or perforating veins, but I just wanted to show elemental, I'm too stupid today, ultrasound. So we go right exploring the target zone. Yes. Perfect. Thank you to my daughter. She needs an applause because she's really helping me. Mama is stressed and daughter is organizing everything. So you see the ultrasound image well, properly? Better than me,
Yes.
perhaps?
Yes, we can see it very well, yes.
Okay, so we have a little perforating vein here on the thigh.
Yes.
And I just selected this patient because of one reason. You tend to make the injection at this point. This is the fascia, this is the skin, this is the muscle. You tend to inject here because you think that you could penetrate better the complete perforating vein, which is the blue one, yes, when you inject it just this level. But remember that you are always injecting in no color mode. And you will not be able to differentiate between the artery, which we are seeing here. Yes, we will inject in this mode, and there is an artery. And the risk of making a puncture of this artery when you do it in black and white and not in color is really high. So the guidelines always say that you have to go for the vein at least 2 or 3 centimeters away from the fascial.
This is very important tip and trick, because if we inject in an artery, maybe the audience would like to know what will happen.
I don't know. I don't want to tell you, but I have to tell you this is a draining perforating vein.
Yes.
This is not the original one. We have to look here upstairs, here.
If you happen to inject in an artery, then you will get an embolization to the tissues. So either you get muscle necrosis or a skin necrosis, and it can be catastrophic. So please, very, very important, this advice. What do you think, Joseph, from your experience?
Yes, absolutely. I support you entirely. And the answer is, unfortunately, the sclerosant is so effective that even the smallest amount of the scleroembolic entering the arterial circulation will result in complete avascular necrosis. And of course, it depends on the vessel. In the lower limb, if you hit an arteriole, you're likely to lose up to 10 square centimeters of dermis. But of course, it gets worse as you approach the axials. So as Dr. Erica has already pointed out, and you can see there on the screen, you've got a clear, perfect demonstration of the color Doppler of the arteriole, associated arteriole, and you can see it pulsating right now. What's most important is to stay well and truly clear of that.
And now I have to, I hope that somebody, having learned from last time, would tell this is not a perforator to be treated. Why? It is only draining. You see that? It drains, it is not refluxing. This, I wanted to demonstrate it to you, hoping that somebody would say, but why won't you treat this perforating vein? The lady has a diffuse build-up of varicose veins on the thigh and gluteal region that drain through this perforator and fill all these parts. So really to make this sclerotherapy, you don't need to make it ultrasound based, because it can just go into the visible parts of the vein. But I wanted to start with an easy case just to show the handling of the syringes and so on. And in the next one, we will do the ultrasound guided. This one, just to make it again, this was such a perfect case with the artery in the perforating vein that I just did want to show you. So now I ask the patient to lay down.
Whilst we're having the patient lie down, Dr. Erika, if I may, I'll just share as well my tips on ultrasound guided. I like to actually split the screen and show color Doppler on one side and the B mode on the other. So I'm getting a simultaneous view of both. Of course, you need to be careful because it may reduce your frame rate and whatnot, but I have it set up so that I'm simultaneously looking at two identical screens, one with color, duplex Doppler, showing the arterioles, etc., and secondly, B mode plane. And Erika, thank you kindly for also confirming that that is a non-refluxing perforator. I find it quite annoying and frustrating when, you know, you're told or asked the question, how do you treat perforators, when in reality you need to know which perforators, and they're not treated any differently. And as you know, Professor Omar, in your clinic, you may actually have scenarios with quite large perforators. Still, having said that, every perforator, if it is abnormal, will be contiguous with an underlying tributary or trunk or both. And what I advise is that, of course, treatment of the associated abnormal trunk or tributary will address the perforator in almost every single scenario.
Excellent, excellent. That's an excellent advice, Joseph. And please jump in at any moment to enlighten us with such a great tip. We're ready for you, Erika. I can see you prepare your phone.
Do you see the veins properly?
Yes, yes, we can see it very well.
So there is also a question, do I perform the sclerotherapy from proximal to distal or from distal to proximal? As this is like a fan, it comes from lots of them. I go and inject via proximal. I go inside the vein. I close distal digitally, and I just inject. And possibly you see, it's okay, that I have, that this one is the color is gone of the vein. Sometimes it makes like fluff, and everybody is like everything is going, is leaving, is flushed with perfect. I will recharge.
How you make sure that you are inside the vein, Erika?
You know, when we used to do liquid sclerotherapy, we could do it aspirating.
Yes.
But with foam, you can't aspire because you don't make a vacuum. You can't aspire. So you can make sure you're not in an artery because it's not pulsating inside, which shouldn't happen. Yes. But it is really, after years of doing it, attention, I will make the next puncture here. You notice when you are inside, and then I give a little bit of the liquid and see it moving along in the vein.
Yes.
As always, when you do it with the camera, it doesn't work as you usually want to. This one is good. This one, you see it moving.
Oh, fantastic.
Flushing flushing everything. Yes, and suddenly it stops, and you get intracutaneous, but it doesn't look like. So this segment is already done. And normally I hope to have it done like I puncture here and this all disappears. And so we now are aiming to do that with the next puncture, we will get this one treated. Puncture.
And whilst you're there, Dr. Erika, I think it's absolutely essential to share your needle gauges, because of the viscosity of foam sclerotherapy, and
this one was what? Yes.
Would you kindly share your preference in needle gauges for doing foam sclerotherapy on the reticular veins that you can physically see?
Joseph, you know me, and I am the person knowing which colors the things have, but I don't know the numbers. This is
22 gauge.
Number 18 in Germany, and I think it's 22 gauge, but I don't know it. And I use the number 21, which is a very, können Sie mal die ganz kleine rausholen?
Which is green in the West.
I use the real small one like this. Have a look. This one I use for the spiders.
Yes.
This one I use for larger vessels, and this one is German number 21, but I don't know the gauges. I think it's 26.
Is this the same scheme that you use, Joseph, in your cases?
Yes, I actually definitely use that little yellow syringe, and that's a 30 gauge needle, I beg your pardon. And that is the one that I think you'll find worldwide is pretty much shared. And your brown one is a 22 gauge. Back to you.
Okay. So now you see I have started upstairs. Yes, here. And a little bit of readiness is appearing. Yes. And I've organized to make this segment with 10 mils, which is what is allowed to give in one session in Germany. So these ones I will have to treat in another session. Yes. And sometimes, I don't know what it depends on. Sometimes you give a little bit here and the vessel like contracts and you manage to do the complete leg in one session. But sometimes it doesn't happen. And I don't know why this is like it, because here still in this part, I still see some veins I would like to treat and here. But I think this rest, I can do it in another session. And now, for me, very important, we go on is putting the stocking to the patient. And the patient shouldn't get up before the stocking is on site. So we ask her to turn around on the back. Don't miss the wonderful tattoo of the lady, internationally known. And we have this kind of device to put the stocking prepared on it. It's a Medi Butler. I'm sorry, Sigvaris, but this one is from Medi. And we can put the stocking to the leg, just putting what's the name of this in English?
Gauze.
Yeah.
What?
Gauze.
Gauze.
Gauze. Okay. Thank you. Go to the leg and the places where the larger veins have been. And it is very important that the patient doesn't get up before we have done this, because we are using foam. And if you get up, the foam goes into the circulation and might go inside the brain or the atrium. And some studies have shown that even if you don't have a patent for foramen, you could also have mini bubbles here in this place. So it is safe, for safety of the patient, that we leave him lying recumbent down and wait just for some minutes. So putting the stockings to the patient is a good thing, because these are some minutes we are having the patient, and we never leave the patient alone until he is completely dressed, because the effort of putting the shoes on sometimes can provoke like a little bit of fainting, or that he sees like little dots when he gets up. This happens. I do about 1,000 sclerotherapies a year, and I always say 4 a year happen to have a little bit of dots in the vision field when they come to the front. And this is like a little, I don't know if it's a migraine, perhaps, because it reacts wonderful to coffee. I always offer them a coffee, and let them there control the pressure, the blood pressure, and then it used to be gone. So now we put down the table a little bit, ask the patient, is everything fine? Perfect. And she will sit down first. So we observe the process of getting, set up. Okay, alles fine. And then she can go and dress, but we will stay in the room. This is very, very important for me. Vielen Dank. Because earlier we used to leave the room and I had one lady that fainted after we left the room, and this was not such a good option.
I would like to take the opportunity to thank Erica Mendoza's daughter for a great, she's holding the mobile camera and she's helping us to learn.
Yes, Sarah is the best.
That's a great effort. Thank you very much. Do you have a comment, Joseph?
Oh, yes. Look, firstly, thank you, Dr. Erica. And I'd like to take up on your point of either scotometer or visual disturbance, which we do classify as migraine equivalents. And I think it's very interesting that you bring that forward. Clearly, and you're also spot on about giving the patient time, because as soon as they try to bend down to put on their shoes, etc., they're in fact inducing a Valsalva, a voluntary Valsalva maneuver, which we've clearly shown and demonstrated that if there is a patent foramen ovale, that you will be basically almost creating a jet from the right atrium into the left atrium, and hence the purpose and reason for our paradoxical phenomena. And what's also important to note is, of course, that up to 25% of the normal population actually have a patent foramen ovale, and in that instance, give that person a Valsalva maneuver, which is what we use, as you know, when we're doing echography to identify a right to left shunt or an atrial septal defect. That's the single best way to do it. In fact, Erica, I've picked up this point, having watched and spent time at your fabulous clinic, and I thoroughly agree. In fact, I actually set the stopwatch and a timer of 5 minutes or so, where I have the patient lying completely still with the limb elevated, and I give them 5 to 6 minutes because that's whole blood clotting time. And in essence, if we have injected a sclerosant-induced endothelial lysis and hence commenced the sclerotherapy process, it does not hurt to allow the clotting cascade to actually close and in fact help achieve complete stasis within those vessels. So I usually lay my patient down and have them elevated for about 5 minutes. Also, Dr. Erica, I take your point. I love your suggestion about working from proximal to distal, and it actually makes a lot of sense. And that is, it allows you to, in essence, treat following the path of reflux. And that is, if there is no reflux and you treat proximally, the foam will not continue distally. So that's logical, and it's a very powerful and useful strategy to take when applying your sclerotherapy. Back to you, Professor Amar.
Yes, excellent. Thank you very much, Joseph, for this very nice comment. There are 2 questions for you, Erica. Do you like to take them?
Yes, of course.
Okay. The first question is from Dr. Baha Rifai. What is the percentage of foam are you using right now? You wanted to use 1% or 3%?
Yes. No,
and
in
why?
this patient, it was only tributaries that we discussed, and so I took 1%.
Excellent.
Because always when it's subcutaneously and it's large veins, I take 1%. If it's spiders or reticular, it depends. I take 1 if they are real prominent, and 0.5 if they are smaller. Then we can discuss the point of foam in reticular veins and in the spiders. because
Yes.
it is always said you shouldn't use foam. The thing is that you destroy a part of the bubbles in this yellow needle, but
Yes.
at the end you are diluting the sclerosant agent with air. And in my
Yes.
eyes, this has two advantages. If you extravasate with a spider, you are extravasating a minimum of medication and air. So the
Yes.
skin lesions are much less since I use foam in spiders than when I used
Liquid.
the liquid one. So
Yes.
I dilute my sclerosing agent as a foam, and then I destroy the foam a little bit with a yellow needle. So it is not mega toxic, but you have reduced the extravasal toxicity, and nobody will tell me that in real little spiders you are always intravasal with your needle. You can't. There is
Excellent.
always a little bit of extravasation, and from my experience, since I do this, I have less like little, when you have an extravasation and you damage the skin, you have like these little things when you have with a cigarette, you make the cigarette out in the skin. Not that I'm used to do that, but these little round lesions that take months to heal.
Yes.
Since I
Yes.
use the foam, I have much least of them.
Excellent. Another question from the candidate. Which compression did you use and what concentration? I think you mean
Yes.
what degree of compression did you use?
I use always when I treat the German class 2, which is 28 to 30 millimeters mercury at the ankle. If it is a person that is very old and frail, I use class 1, which is 15 to 22 at the ankle. And if you think that in all the rest of the world, the class 2 is our German class 1, I think that using around 20 will be good, will be fine. But I don't think that there are any comparative studies between the compression. I think it is very important to put the compression on before the patient gets up to reinforce the emptiness of this vein as long as possible before starting the ambulation. And yes, this is the...
Okay. And a question from me. You did mention very good point that when you put the foam, the needle, you cannot aspirate blood to make sure that you are inside the blood vessel.
Yes.
But have you used the hockey stick probe with the duplex that can magnify the 1 millimeter and 0.5 millimeter vessel, and then you can actually see the small 30 gauge needle inside the vessel? But your advice is extremely nice, which injects slowly. If you see the vein start to disappear, you are in. If it extravasates, stop, either go back or forward, make sure. But this takes experience. Is that right, Erika?
Yes. I'm doing this since 20 years with this foam sclerosis.
Yes.
And at the beginning, I always was very confounded by the fact that I can't aspire. But first of it, with time, you notice that you are inside the vein because you have a little of resistance and then you are there.
Yes.
This is one point. And the second one really, and not only to make sure you're intravasal, but also because you will have less complications if you inject very slowly.
Yes.
Most of the skin reactions and skin lesions are because you have injected very high pressure very quick, and then you have the pressure going into the arterial capillaries backwards.
Yes.
And
yes.
you have to avoid that by any means. So always inject smoothly, always. And this helps you seeing that you are in the place.
Yeah. Do you like to comment, Joseph?
Yes, I thoroughly agree, Dr. Erika, and that is it's absolutely essential that you get the pressures right. So, for example, I could easily cite for you an example where I would use 0.12% STS solution in a telangiectasia, but if I use enough pressure, I can actually induce an ulcer. And the way in which that happens is that You're in the capillary vasculature and you're rising the STS concentration or sclerosing concentration in the arteriolar capillary end, which is enough to, in fact, induce an avascular necrosis. So even if you use the maximum dose in a tiny vessel, but you inject it very slowly and gently with very low pressures, you're going to reduce the likelihood of arterialization of your sclerosing. Point number one. Number two, the other thing Dr. Eric has mentioned there is the veno-arteriolar reflex, which is really quite fascinating. And that is, as soon as we inject a sclerosant or an irritant into the venous system, we're actually getting a venoconstriction and then opening of arteriovenous shunts. And that's how we explain the phenomenon of ulceration at remote sites, not at the site of injection, but at other little sites, when we know we're definitely in a vein. It's purely simply because we're actually reverse injecting and introducing sclerosing into a veno-arteriolar reflex, and then, of course, the blood is refluxing into that. So the key is reduce your pressures. Back to you, Professor.
Excellent. Yeah, no, thank you very much. And I think recently there is some paper about they want to train robotics to do the injection for sclerotherapy because they are very accurate. They are femtosecond accurate. And we are very good in imaging. And now, the HIFU machine, you get the image and you get the robotic arm and it decide where to fire the high intensity ultrasound. I'm sure this machine with the robotic arm injection, but it will be very costly. And I got another 3 or 4 questions, very interesting to you, Erica. Yes. So what do you like to do? Do you like to take one or two and go to the patient, or what do you like to do?
I am seeing the questions, and the one is, how long would you put the stocking?
Yes.
And this is very important, and we finish it because it was the first thing we commented. The stocking, I put them 2 weeks. Because my experience is that it takes 2 weeks to have this brown hyperpigmentation forming, and I guess it could be reduced a little bit with the stocking. And I really regularly make a control of the patients after 2 or 3 weeks. Everybody has to come, and we look if there are some touchable hard places in the vein, and we always, with a number 1 needle, the large yellow one, we make a puncture and express this. Perhaps we can make another session about how to deal with the little ones and with the after treatment, because this is, in my eyes, when you do this, I treat real large varicose veins, if you have seen, and you will have less skin pigmentation if you have them retreated after 3 weeks, making this punctures and expressing the gelatin you have. And there is one very important question also about why I don't give 10 mils in one moment. If you see, it is prohibited by the German guideline. The German guidelines say you can give 2 or 2.5, full stop. And this is what I do. But I think it is good from the strategic point of view. Only if you do a large saphenous vein and you put a catheter in, then you can, of course, deliver while you withdraw the catheter, and you can put the 10 mils in one. But if you think of it, you are withdrawing the catheter, and so you are delivering it at different points. You make a higher usage of your sclerosing agent if you distribute it. And so as time passes, the foam will get worse. So it is good to take a little amount, put it in, take a little amount, and so you have always fresh foam and you can distribute it. Yes?
Excellent. Yes.
Okay.
Excellent. That's great.
A wonderful case and a wonderful patient, of course. Mr. Mensing has a transtibial perforating vein, which is not so often to be seen. And there is only one publication about it, and my experience is that it is always after a lesion of the tibial bone, because why on earth should there be blood coming out of the tibial bone? Yes, and as we will see in this case, there is really a depression in the tibial bone, and then there we see the blood coming out. So now everybody gets in place. I share my screen again with my ultrasound, this one, and move. I hope everybody sees me. Is this okay? And now we need to see, das war dieses Bein, no? We need to see this place, please. Everybody sees the camera? Okay, the patient came with a varicose vein here on the calf and some spiders there. And if you go with the hand, you always can, here is a hole in the tibial bone. And I made an ultrasound of course, the great saphenous vein, thinking this could be a tributary of the great saphenous vein with this presentation, but everything was fine. And now I go, you see these varicose veins here? Yes? You
Yes,
see
very clear.
And suddenly there is something here happening. And if you look at it, you don't find it. I put the patient on the head down and everything, but I didn't find anything. And then I came across this thing. Let us go back and the longitudinal view of the bone. This is the normal view of a bone, with no injuries. And let me find the place. This is as always when you are in a film situation, you don't see it. I'm sure it is there. Did anybody of you already see a transtibial?
Yes, it's a live transmission effect.
Yes. Now here you see. Geben Sie mal die Zehe am Fuß.
Yeah, wow, that's very interesting.
Stell dich mal hin. You see that suddenly the reflux disappears from somewhere. Nochmal hinstellen und Zehe heben und runterlassen.
So, Erica, this is a venous malformation of sorts.
Yes, there. No, here it is.
There you go. That's fantastic.
This is a bone defect, isn't it?
Und runterlassen. And you see that there is a hole in the, I can make it bigger because it won't be deeper. You see there is the hole in the bone.
That's very interesting.
Yes. And some of the co-authors of the paper said that these were nourishing veins, which could possibly be, but if you touch the leg, you see, I mean, here you see it. There, it could be an artifact, but there is, the bone isn't there is a hole in the bone, and you could imagine that there is a little bit of bone going inside. And what is interesting for me, drehen sich mal is Alfred Obermeier from Melk, married with a radiologist, published that these veins come from the posterior tibial vein. So if we have a look at the back, I would go down with the color here. We should find a flow. Now I'm pressing on just on the tibial, I mean just on the tributary in the tibial point. And you see how there is a flow through the bone to the tibial vein. You understand what I mean? I'm not good in English today.
Yes. Erica, would you kindly confirm by putting spectral Doppler on that? Is that arterial, venous, or just high flow shunt?
Okay. No, this. Wait. My friend Joseph always asks the difficult things.
No, it's,
Wait, this
I
is a
think it is
vein.
needed.
This is a
Yeah, this
vein.
is vein. Yeah.
And now I press, 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 press. You see, there is a the anatomy of the tibial bone is that it is drained by the tibial posterior vein. There is a tributary in the head of the tibial bone draining into the tibial vein, and where usually it is drained. Drehen Sie sich noch mal um. So today, our aim is to treat this transtibial perforating vein. And the first time I wasn't aware of the problem. Here you see it very well. Here really you see it very well. I wasn't aware of the situation that this could be transtibial. And we opened the patient because I thought it was a perforating vein. And we did, this was 20 years ago. I wasn't so used in foam sclerotherapy and so on. And we opened, and in the preparation, we discovered that this was coming out of the bone. And it was no point to close this thing. We couldn't. So you should use bone material to close that hole. And so since then, I never again touch this surgically, but always do it with foam sclerotherapy. So now we change to the recumbent situation, and I will use, because, sorry for the word, but this perforating veins are bitches. They will not be closed with one session. You have to explain to the patient that it will take 2 or 3 sessions, and I always do this with high concentrated foam sclerotherapy, even though I'm very far next to the skin, because there is no, the pressure inside the bone is just the hydrostatic column. There are no muscles protecting this vein, and it will take really 2 or 3 sessions high concentrated foam sclerotherapy to achieve the result. And in this case, I will position the probe at the opening, and I will inject in the tributary so long as to see that there is foam going in the hole. Yes? So let's try. Let's try and do it. Ich schäume, genau. Everybody hears me, sees me, and everything is fine?
Yes, we can see you and hear you very well. I'm just asking about the pathology here. Do you think this is a draining vein from the tibia out, or is a connection of vein from out going in to the bone?
No, it is from tibia going out. We can show you this. This is a good question. Sorry, I'm disappearing, and I will just take out a second.
No
because
problem.
I had a connection problem earlier, and I will need
So
to.
if this is a draining from the tibia out, is this pathological that you should close it and it will drain somewhere else? Or is it normal to have this? Or is it a sign of maybe other disease like osteoporosis or some other low calcium disease that can manifest to this?
Yes, there are not so many cases published.
Yes.
There are not so many cases published of this, but we will show you exactly. Nehmen Sie das nochmal weg.
Okay.
Patient has been lying down. Wir müssen das auch nochmal wegnehmen. And we'll stand up and we will show you that it's refluxing. It is obviously refluxing. Einmal bitte nochmal hinstellen. Where are you here? You see this?
Yes, I can see it very well.
Obviously refluxing.
Yes.
And as long as he's on his feet for some time, this is the recumbence, the dependency maneuver we have been talking about in other sessions. It is very, very obviously refluxing.
Yes.
And why I should treat it is I'm always very reluctant to treat the vein just because it is there. But
Yes.
as to my experience, and I have treated 10 of these veins only go further. They go to more and more and more, and the thicker they are, the more difficult it is to treat them. And I had one patient that had a nearly ulcer in this place just next to the hole. Einmal bitte wieder hinlegen. So thank you for coming to the question if it's refluxing or not. They are always refluxing. They are always refluxing.
Excellent.
Otherwise, you wouldn't see them. You wouldn't come across that there is a. Yes. Now I have list.
And you don't want to do a CT venogram or assessing the intratibial venous pathway.
With which point? I mean, it has been done demonstrating that it is connected to the tibial vein. Would it change my treatment approach?
Yeah, that's a good question. Yeah,
no,
it wouldn't. No, it wouldn't.
So why to do something that wouldn't change my treatment approach?
My brain, yeah. I'm just interested what happened to the tibial drainage of the bone marrow inside. If this is, let us say,
as you see, it has a connection to the tibial bone through the normal feeder of the bone.
Yeah.
So, gleich gibt's einen Pieks, ich sag Bescheid, ja? I will make my foam, my 3%. This is a 3% dry foam, as I told you.
Okay.
And I will aim to give the first one. My hands are wet. This is not good. First, to focus on the hole.
It will be very interesting to see what is the sequence you injected. Do you inject the one immediately bone out, or you take out and go backward toward the bone? It will be very interesting.
So there is the hole.
Yes.
Machen wir noch ein bisschen Jelly hier hin. A little bit more of jelly here. There. And now I go a little bit further down. And inject, but it is not. It is advancing. It is coming. But it didn't. My 2 mils didn't reach the hole. They went into the distal veins. So I will have to reform, and by my next puncture go nearer to the hole. In this case, as there is no artery, I can go next to the hole. Did you see the foam expanding?
Yes, it was clear, yes.
Kann ich jetzt nochmal 1% haben? Oder warten, noch nicht wegwerfen, aber ziehen Sie mal in der großen nochmal 1% auf. Are you okay? Sind Sie okay? Ja? Spannend. Where is it? There is it is already gone. Here is the hole. It is already come here. Nevertheless, I would try and just inject here into this. Yeah, it is a painful place. There, I would just inject, and of course I've gone a little bit past.
Yeah.
But I want
we can see the foam going in. Yeah.
Yes, a little bit more of. So now I will clean this, and I see that I have some tributaries still here around, and I will treat them with 1%, just to. My idea is if I foam around, I stop blood from going out into the place. Liegt es nicht da noch?
Dr. Erika, with due respect, this is a perfect example, I believe, for perivascular infiltration of tumescent anesthesia, because you can shut down quite large, thick vessels, achieve stasis. And the thing that we need to remember is, of course, that sclerosant power is dependent on A, sclerosant concentration, B, sclerosant endothelial wall contact time, C, removal or reduction of runoff or flow. So you really want to achieve that stasis. And I think this is a perfect example of where I would love to use tumescent anesthesia just to actually compress, seal, and close off the vessel. But of course, not always necessary.
Okay. So now you
that's
see
absolutely right. Yeah.
still some tributaries here. I will inject foam.
You know, the pain tolerance in Germany is quite high to other different countries. So maybe
no, it's my smart and lovely fingers. I'm sorry.
Oh yes.
Exactly.
That's more important.
Exactly.
Yeah.
My experience with the patient is suffering pain because in the tibial bone, in this region, we are very, very sensitive. There are lots of nerves, and he's kind enough not to shout at me. I always think like if you have the water coming out somewhere and you put lots of sacks around, you will stop it better than only closing the one hole it comes out. You know what I mean? So
I know what you mean.
In this case, I always try to make all the circumferential visible veins, I treat them also, although they are already very empty of liquid.
Yeah.
So
at least it will decrease any recurrence when you do that.
Yes. Jetzt bräuchte ich nochmal Schallgel. Ganz dolle hier drauf. So, and now we will have a look what happens with the... No, it stopped.
It's a very interesting case, Erika. We really would like to thank you very much for such a rare case, a rare procedure, and really a fascinating overview about general management of sclerotherapy.
Yes. Now I can't see the the hole is the hole is closed.
Yes, it's closed. Yeah,
it's closed. So, but I tell you, I will see the patient on Tuesday.
Okay.
And I hope on Monday, tomorrow, in 2 days, and I hope that it will be closed. Normally you see it very properly. If it is closed, it's okay. If not, I will redo just the same again with 3% on the next to the place. Yes, and and I don't know the guidelines. No guideline talks about heparin in case of transtibial treatment. And
yes,
just to be sure, I give the patients low molecular heparin. In this case, I'm having tinsiparin prepared because what happened if the bone marrow would thrombose or have a reaction to the... Perhaps I have so many interesting people around in the room. What would you recommend, to give or not to give heparin?
That's a very good question to Joseph to jump in, and I will reply.
Joseph, yes.
Yes,
and I'd be honored to answer that question, my dear friends and colleagues.
Yes.
I would start by saying there's unfortunately absolutely no evidence to support the use of anticoagulants, unfortunately. However, if we use anecdotes and if we use clinical experience, in my experience, I would say that I would definitely evaluate the clotting risk by obviously the patient's age, clotting history, presence or absence of thrombophilia, concomitant use of certain medications, etc. So I think it's always going to be a personal thing. Unfortunately, we don't have any evidence to support the use of anticoagulants in this situation, but also in places where we're using the thermal endovenous laser ablation of significant trunks. And I think it's important and essential not to rely on anecdote. However, having said that, no advice. In my case, I tend not to use anticoagulants readily, because we need to remember there's a 1% risk of bleeding, a bleeding risk, and that could be intracranial, it could be GI, rectal, or peptic or gastric bleeders. And I think if you're treating enough patients, 1 in 100 is a significant risk. That's my advice.
I will probably will take the hold of the other side of the stick. Definitely, there is no guideline. Definitely, there is no grade A recommendation. But what I would say is the risk factor for getting thrombosis in patient due to age, diabetes, hypertension, other factors, and I am using a thrombotic agent, which is the sclerotherapy. I would be much happier putting him on low profile of anticoagulation, either with NOACs or with antiplatelet, and follow him up for a week. Maybe this is because I'm a vascular surgeon. We see a lot of problem with clotting, but this is by no means a recommendation or by no means is a guideline. But let us say I will sleep much easier if I anticoagulate him for 2 weeks and see how it goes. This is how it goes for me.
Yes, I used to do 5 days, because this is the timeline where you should not make a thrombocyte count in the patients. And you are completely right, there is no evidence, and I give this only in situations which are not described in a guideline like this. And also this patient had a prostata carcinoma. It is gone, but carcinomas are also a kind of a risk factor. And I do give prophylactic anticoagulation also if I treat very large perforating veins or recurrent. I think the next patient will have a recurrence in the groin after high ligation, and he will or she will receive also this anticoagulation for 5 days, because I'm treating really next to the deep vein, and I can't avoid extravasating, and I will compress the region. But I'm completely with Joseph. There is no guideline, and everybody should do like he thinks. I had in my whole life, I mean, I don't make a duplex on every patient, but I see every patient after 3 weeks. And if I have the clinical suspicion or they have pain, we make a duplex. And I remember 3 cases before 2020 and 3 cases in 21. This was the time when I didn't know that COVID vaccination was also triggering thrombosis, like the COVID disease itself. And when the lockdown was, when the lockdown was taken off, I started doing all the things we didn't do in the winter. And I had, in 3 weeks, I had 3 patients with thrombosis after sclerotherapy, because they had incidentally had vaccine. So now I say, if you had COVID, you won't be treated by me the 4 weeks after. And if you are planning to have a vaccine, you won't be treated 4 weeks earlier and 4 weeks after. This is my routine, but it is, of course, also not guidelined.
Excellent. We have plenty of questions.
Yes, please, go on. Go ahead. We are changing the patient, so I will stop the...
Brilliant. Okay. So the first question from Dr. Lily Marion. Which steps do you like to prevent and minimize the skin hyperpigmentation afterwards? Which steps do you do to decrease hyperpigmentation afterwards?
I didn't show it because the patient had to leave, so we have to go on. One is we put these compressors in the tibial bone to make an extra compression on the place inside the stocking. We ask them to ambulate. We ask them to wear the stockings the first night and then 2 weeks. I use little amounts of foam and wait how it, sometimes the concomitant vein will reduce their caliber just because the inflow from the proximal vein has gone. And of course, this is not a prevention, but it is a treatment 3 weeks after making this punctures. I think that this reduces the time until they go. There are some people putting 2 injections and injecting the foam here and extracting the foam there, saying that the skin, the tissue contact is enough with 1 second. I don't know. I think that is all very sophisticated. And with my around 1,000 sclerotherapies I do a year, I have 1 or 2 patients only that will come back next year saying, look at this. And they normally are red-haired and very, where the skin is very, very white. So
Yes.
I don't know. Normally, this is gone after 3 months.
Okay.
Yes.
Do you have any tips and tricks, Joseph, for this hyperpigmentation?
Oh, absolutely. First, I thoroughly agree with you, Dr. Erica, on immediate compression and, of course, the follow-up compression therapy. That will significantly reduce the incidence and the severity of hyperpigmentation post-sclerotherapy. But let's also keep in mind some extremely important points. Firstly, if there is residual reflux, this will invariably result in persistent or apparent hyperpigmentation following sclerotherapy, when in fact it's a failure to address.
This is
Secondly,
point.
So that's extremely important. You need to ensure that you've treated all the reflux. But secondly, more importantly, let's look at the causes for pigmentation. And in fact, there are 3 clearly distinct sources. First and foremost, tissue trauma. In response to tissue trauma, my friend and colleague Prof. Parsi has demonstrated that in fact you're getting a melanin release in response to increased melanocytic activity. So just inflammation itself will produce pigmentation, and almost all patients will get some pigmentation which is residual. Then you get into the more resistant or recalcitrant pigmentation, and that is hemosiderin breakdown. So as soon as we get a bruise, we're getting a release of red cells, and then of course we're getting minor stains. So we've shown as well that with sclerotherapy you get the hyperpigmentation as a result of increased activity in melanin and melanin deposition, which is similar to what we get with sun exposure. Secondly, we're getting iron deposition and hemosiderin. Now, the third most important source will be, I beg your pardon, on the question of bruising, if, as Dr. Erica Mendoza said, if you do not release the trapped blood, you have actually left a container of red cells which will just over time slowly, gradually extravasate and then, of course, deposit hemosiderin. So it's essential that you treat the post-sclerotherapy trapped blood. Thirdly, finally, if the individual has either excessive iron on board or are taking iron supplements, then the logic and common sense says that you're getting hemosiderin staining as a result of that. Back to you, Professor.
Question for me, Joseph. Yeah. If this is inflammation guided, shouldn't we recommend them to take any oral anti-inflammation drugs the day after?
That's an excellent suggestion, Dr. Erica. The simple answer would be we don't have any studies or proof to show that it works, but absolutely by reducing the degree of tissue injury, we're going to reduce the degree of transient hyperpigmentation. But like with your patients, Dr. Erica, as you know, the vast majority of them will get pigmentation that will completely disappear after 4 to 6 weeks. And I think when you're doing hundreds or thousands of cases per year, you quickly learn about what is helpful and what not. I might also add that I've in the past extensively used hydroquinone and bleaching agents and whatnot, but that's a complete waste of time. So please, with your residual and recalcitrant hyperpigmentation, 1, check for concomitant or associated reflux or residual reflux. 2, make sure you've released all the trapped blood. 3, make sure they're not taking any iron supplementation. The only fourth bit of advice I would like to give here, if I may, particularly in Australia, is UVC exposure and sunlight exposure. Unfortunately, you can go from transient pigmentation, in many cases in my patients here in Australia, transient to actually permanent pigmentation, and that's actually caused by UVC. And again, that's where we're getting permanent damage to our melanocytic activity, and you're getting upregulation. And back to you.
This has been a very important point, Joseph, because I do this only in winter. We had a discussion in this international phlebology groups if this is important or not. I always explain my patients. You put ink on the skin and you make the tattoo with light. Yes, you put the ink and you fix it with the light. And if you have iron in the skin and put light, you will fix it like a tattoo. And you will change.
Because it acts as a chromophore, and as a chromophore, it's increased the absorption and, of course, the reactivity to the same dose of UVC.
Yeah.
So I tell them not to have some baths until 3 months or until the skin pigmentation is gone.
Excellent. So we'll go to the next question by Dr. Atilia Pascas. In case of this patient, do you recall her for clot elimination? So if you think there is clot where you done sclerotherapy, do you bring the patient to remove the clot?
We are talking about this hyperpigmentations in the vein.
Yeah.
Yes, of course. I will bring her back in 3 weeks and I will do clot expression like I do with everybody. I look at them. If there is the vein is hard, if you can palpate the vein and they are like little lentils inside, then you have to make the puncture and express it. And I do it always.
Yeah. Okay. And I know one of the candidates is very famous phlebologist from Austria, Dr. Muhammad. He's expert in using laser for skin rejuvenation. And he said he can really help a lot in post-sclerotherapy pigmentation by a lot of laser machines. So again, there is too many options to treat pigmentation with the new technology of skin rejuvenation and Q-switch laser and nano fat treatment as well. I know Dr. Muhammad is expert in that. And I got another question. Could there be a risk of deep venous thrombosis? Question by Francesca Forti. So this is question to Erica and Joseph.
Okay, well, I might take this.
Yeah,
Dr. Erica, we can't hear you, my dear.
Yes, sorry. I didn't hear the question because I was putting the patient. Would
That's
you
right.
answer, Joseph?
Yeah. The question is, could there be a risk of deep venous thrombosis with such a procedure? That's a question from Francesca Forti.
With foam sclerotherapy, always. I mean, you're putting an inflammatory agent inside a vessel, and this can produce, like everything we do to veins. Always we treat veins, we can produce a clotting, and when we give the patient a big with something else, a trauma to the vein, we can produce clotting. But the difficult thing is to handle out the risk of the clotting and how do you prevent it with other things like compression, moving, and so on.
Excellent. Would you like to add, Joseph?
I'd like to firstly thoroughly agree with Dr. Erica. This is an extremely important component. Sclerotherapy is a DVT risk-rated procedure. The baseline risk of DVT is 1 in 5,000 for the general population. Sclerotherapy increases the risk by 5 to 10-fold. Oral contraceptives increase the risk 5 to 10-fold. A long-distance flight, 5 to 10-fold. When you add more than one risk, you actually multiply. So someone with varicose veins has a 5 times increased risk, and as soon as they have sclerotherapy, that goes to 50. So you need to counsel your patients, and I quote about 1 in 500 to 1 in 1,000 DVT incidence rate post-sclerotherapy in my cases, and of course we need to cover that during consent.
Excellent. So we are ready for you, Erica, for another third case of clinical sclerotherapy.
Yes, you can go ahead. Our third place, it is Mr. Harder. He has really large varicose veins. Stell dich einmal hin. We have planned to do, this leg has a saphenous vein reflux filling all this. The other leg has, dreh dich einmal nach da. Nach da. He has a small saphenous vein also on this leg and on this leg. But today, drehen Sie wieder zurück, we are going to treat this. Wir drehen sich mal zu dem. Do you see the?
Yes, we can see. We can see very well the groin.
Yes.
The groin.
Yes.
Groin
he has never been treated by his veins, and we really didn't find out why he had this. He was not pregnant, by the way. Schwanger waren Sie auch noch nicht, oder? This is
not a joke by Erica. In NHS in United Kingdom, before you do plain X-ray on a male, you should ask him if are you pregnant or not.
No,
this is by regulation, unfortunately.
Don't tell me. Okay, so we start doing the exploration. When he came, I said, but you have had like surgery here or a catheterism or something. No, seit wann haben Sie das? He doesn't remember when it started, but it's a long time ago that he has it. And I just want to show you the problem. Of course, you can operate this. You go to surgeon, you can operate this. But I just start here, mid-thigh. This is the great saphenous vein, if everybody is agreeing with me.
Yes.
And here we have a little perforating vein. I go up, just the anatomy in the first point. And here you see it is large, and in the next moment, here is a vein, a tributary coming in, joining in, and here is one joining in, and here it is really small. This one is the great saphenous vein, and it is refluxive, but we see that the saphenofemoral junction, we will see it here. Here we have it. It is refluxing, but not so much. It stops a little bit. The most important reflux thing is the accessory anterior vein here. You see them both. This one is the great saphenous. This one is the anterior accessory. And we go inside to measure. And you really see a large reflux. So if a person carries these kind of very extremely tortuous varicose veins so many years in a country where all the thing we do is operating, you can imagine that he didn't want a surgery. And this is why he came here, because he knew that I'm doing it different. So I am completely with you, Joseph. You are thinking this one would be a wonderful case of putting adrenaline around the vein, and I'm thinking of doing it anyway. Because with adrenaline, you could reduce the volume of this.
Absolutely.
Really
and further, yes, and further, as long as you've got a secure cannular access to the primary source of reflux, I think it would be fabulous. And the other thing is, as you may recall, Dr. Erica, when you visited me in Sydney, I love to, rather than flush the cannula once you've got access, rather than flush with plain saline, I actually flush with 0.5% STS, which commences, firstly, causes vasoconstriction, secondly, gives you a degree of endothelial lysis, and thirdly, increases the power of your sclerotherapy, of your foam sclerotherapy. Finally, it also reduces the amount of volume required. And this is obviously an aneurysmal dilatation and somewhat a venous. It's been quite existent. I'm wondering about the inferior
Just a second, I have to ask the patient something. Vertragen Sie beim Zahnarzt die örtliche Betäubung?
Ja.
Gut. Ich würde nämlich, wie wir gerade diskutieren, ein bisschen Adrenalin ganz verdünnt herumspritzen. Dann macht sich nämlich die Vene, zieht sich schon mal zusammen. Ja. Und dann kann man das Ergebnis verbessern. Ja? I just had to ask him if he, normally when you go to the dentist, you receive adrenaline in the local anesthesia. And some people don't react very well to adrenaline. So I asked always if they tolerated so my plan would be, if you see this one here, this one is the accessory anterior healthy in this place.
Yes.
And then going on. So I would try to cannulate, it ends up in this one. I would try to cannulate this one and to cannulate the great saphenous with Avocath. Bräuchte dann auch zwei blaue Infusionsnadeln.
Can I play the devil advocate in this case and just ask, can it be an element of pelvic congestion syndrome in this patient, or do you think the reflux is only from saphenofemoral junction? Can it be other?
I think it is really only the saphenofemoral junction in this place. It is very, very obvious that it comes out here, but we can just have a look. This would be the epigastric vein.
Yeah, is it not the superficial inferior epigastric?
I mean, it comes from above. Sie haben jetzt, Sie haben jetzt das auf 10 aufgezogen. Nee, das ist 20er, aber nicht das mit 10. Sie müssen das mit 10 Millilitern erstmal auf. We are preparing the adrenaline. I will just step out and you discuss something, please.
Okay.
So what's your feeling, Joseph?
Yes, Professor, I think this is a perfect case for the application of what we refer to as empty vein sclerotherapy. And in essence, it entails, firstly, a vascular access. So you need secure access either via an 18-gauge angiocath or any other. I actually, believe it or not, just use hypodermic needles for vascular access, and I would gladly show you at some time. The point is secure vascular access, firstly. Secondly, inject a very powerful and potent vasoconstrictor, and that would be STS solution. I would use 0.5% STS solution, about 0.5 ml or 1 ml, doesn't take much at all. And then, of course, I would infiltrate with tumescent anesthesia, and the tumescent anesthesia I would use would be 1 in 2 million adrenaline and 0.04% xylocaine. I've been using this concoction for the last 20 years or so. And also, of course, we need to, by rights, monitor the patient. So you should at least be doing basic vitals, of, pulse, blood pressure, and oximetry, because occasionally you will get an intravascular bolus of adrenaline, even though at 1 in 2 million, that could be enough to cause a tachycardia, which is not a problem. But every now and then, if you're not careful, you will get either VT or even VF, and you've got to be there and ready to resuscitate the patient. So I think you need to make sure you've got a crash cart trolley and be ready.
Absolutely, Absolutely. So you create a spasm around the vessel to collapse, and then you do your sclerotherapy at this stage.
Absolutely, and I can show you in many instances where we do it. You start with a 10 or 20 millimeter diameter vessel, and when you're ready to give the foam sclerotherapy, it's down to about 2 and 3 millimeters. And then if you do the calculations, you can obviously extend a hell of a lot further. Back to you, Professor.
Okay, thank you very much. And Erica, we're ready.
Yes, so we didn't have that prepared, so we had to do so. I took a 1 ml ampoule of adrenaline. and I diluted it in 20 mils of saline, and I took 4 mils of these into 1 liter of saline. So I have diluted it to, it is 1 to 0, 0, 0, 0, lots of zeros there. So to have a really diluted concentration of adrenaline. And
that's 1 in 4 million.
Now I will prepare the field. I always put the jelly first, and then I apply from both sides. I apply because if you put first the alcohol and then the jelly, it tends to move away. So
I like the use of the spray, Dr. Erica. That's a brilliant idea. Where did you get that from?
The big spray.
Yeah, the alcohol spray.
This is a German producer.
It's a chlorhexidine spray, which is a general antiseptic that we use in theater if someone is allergic to betadine. It's chlorhexidine spray. We usually sterilize the probe, the duplex probe with it, the endoscopy. A lot of tool can be sterilized this way. Chlorhexidine spray.
Excellent.
Yeah.
Now I will introduce an avocado in the great saphenous vein. So, jetzt kommt eine Nadel rein. No? Nicht weinen, nicht schreien.
So now you are injecting the adrenaline.
No, I putting the avocado inside the vein. Kannst du mal die Nadel? Because
if you inject the adrenaline first, you will lose access.
Precisely.
Yeah.
So it's just achieving secure vascular access.
Yeah, no, it's a very nice idea because you decrease the amount of lumen of the vessel and expose the intima, and you just fire the sclerotherapy to the intima. So surely it will get a powerful impact. It's a very nice idea. You've been using it for 20 years.
Yes, sir. And what's more is that it reduces your demand for active dose of medication. I actually use a maximum of 5 mils of foam in any one given treatment session. And that because you're using less drug, you're going to reduce your incidence of adverse effects accordingly. And you do not lose benefit or efficacy or if you like, results purely simply because you're maximizing your return.
Absolutely. This is really a great advice to all our 100 candidates who are listening to us on the Zoom and another couple of hundred on the Facebook. So this is a great advice. Yeah, great advice to minimize the dose as you can. And I like when you mention when you're making foam, you are manufacturing a drug. So there is a process that you need to be professional and you need to minimize the amount to get the maximum better success and to have really the complication away from you. That's a great advice, Joseph.
Precisely. I thoroughly agree, Professor.
Yeah.
Okay, so I have put 2. Do you see them? One in the saphenous vein and one in the superficial. This one.
Fabulous.
But I hope it will keep there.
Okay.
Because it
well,
was...
that's extremely important. And as you're saying, Dr. Erica, you need to have secure access because if you lose that access, you've lost the opportunity to actually intervene. It's not the end of the world because you can always come back and do it, but you really must ensure that you've got secure vascular access.
Yeah.
So now we are taking out of my mixture, we are taking 20 mils. I don't know if I will need so much, but this is the mixture with the adrenaline.
Yeah.
And I will take a brown needle again.
Yes.
Because it's really...
Yeah. And Dr. Erica, I would use anywhere from 20 to 200 mils of tumescence. There's absolutely no harm in using adequate volume to achieve the degree of compression.
Yes, and this is a real little zone. I would just take I will start with 20 mils, and if I need more, I will go on and have more of
Excellent.
it.
So I'm very eager
what I
to
want-
see where do you inject it, Erika. Yes, please.
Yes. I am injecting it. You see, this is the aneurysma of the accessory anterior. Yes.
Yep.
And I will go beside the vein, not to go inside. Piek's nochmal. And
Start infiltrating.
you see the infiltration. Yes.
Yeah.
Where
Yeah.
it comes. Geht es?
Is this the same technique that you use, Joseph?
Exactly the same technique. The only variations are vessel, access size, access, whether I'm using a needle or an 18 gauge angiocath. And I just add, I also add a tincture of xylocaine, just so it produces some anesthesia. And you also get vasoconstriction with the xylocaine as well. But this is exactly the same. And I would use in a session on average for, a sclerotherapy session, I would use anywhere from 200 to 500 mils of tumescence to actually achieve adequate compression. We all use it with endovenous laser ablation, but I think it's a shame that you don't take advantage of the same principles here with sclerotherapy.
I can tell you why. This is, I can't put local anesthesia in the patient who is driving a car afterwards. In
Precisely.
Germany, this is not allowed. So I would, when I do my foam sclerotherapy, people usually afterwards go back to work or something like that. And so I couldn't do this if I put local anesthesia. And I think that the volume of liquid there, I'm with Joseph, is a 1 point. But if I put 200 mils of liquid in a leg, this is a question of money. Because normally then I use a roller pump thing, like we use this pumps we used to do the infiltration in case of intraluminal treatment. And this goes within the price. But when I do foam sclerotherapy in Germany, I charge 80 euros, which is the highest I am allowed to charge. And you can imagine that I won't pay the complete, alles gut? Yeah. I wouldn't, if I put the roller pump to work and every thing I need around it, it will cost me more than I'm earning for it.
Absolutely.
This shouldn't be the thing to decide why to do something or not. But at the end of the day, you have to be able to have a reimbursement.
To be financially sustainable. Yeah.
Yes. And now you see that the aneurysmatic thing is gone.
Fantastic.
It is nearly gone. It's really small. And now I will make my 3% foam. And as always, when I do a film, what will happen is that this one will have gone, I hope not. But this is my foam. Brauche hier eine Unterlage und dann nochmal
and if it does, Dr. Erika, the risk is really very small because it just means you may have to come back and do it on a separate session. It's a very small price to pay for the tremendous benefit you get that from because if you were to inject that aneurysmal dilatation with 1, 2, 3 or 4 mils, let me tell you, all of that is going straight into the deep system and then across the right to left shunts, and it's not worth the risk to and for the patient.
Yeah, absolutely. It minimizes the amount of foam dramatically.
Precisely.
We will see what happens if it's intraluminal or not.
Yeah.
And Dr. Erika, this injection that you're about to give is both diagnostic and therapeutic. So diagnostic because you'll see what's happening and you'll see what the size of the vessel is and whether there's stasis or not. And of course, it's therapeutic.
Yeah, absolutely.
So
in the beginning of my career, we used to deal with these cases with surgery, which was horrible.
Yes, absolutely.
So what Eric is doing is quite magic.
You see that it is gone up to here and here and here.
Yes. That's fantastic, Erica.
And I will do next step. Ich brauche eine Nadel, ich brauche eine Spritze. Ziehen wir wieder nochmal 3% auf die neue.
I'm very happy with this case because a lot of the candidates are vascular surgeons. So this definitely shows the way for massive varicose vein can be treated.
I will
endoluminal technique. Yes.
As you see here, we still see a vein with the eye. And I will go here inside and will give a further dose. I think I'll have extra vasated.
It's a great case, Erica. Great case.
Thank you to hear so. And now I will go to the great saphenous vein where I have introduced another
vascular access.
My trick, in this case, I will just take the rest of it into the larger, which is 4,5 mils. Ich brauche einen Tupfer und ich brauche ein Schallgel gleich. Tupfer brauche ich jetzt. Oder Schallgel. I have two great assistants with me, I have to tell you.
Yeah, please thank you the two assistants.
And a great patient.
And a great daughter as well.
And Dr. Erica, the only other thing, as you know, when you came to my practice, you know I love to use ice, sterile ice to actually...
I can't talk now. I have to do something. So now my assistant is closing the distal GSV.
Yes.
To oblige the thing I am injecting to go to the head. Yes. She's closing this here with the digitally. And I can show you that the volume has gone to the saphenofemoral junction perfectly. Of course, in the femoral vein, you see a little bit of it. It was able to be seen, no, not so much.
Excellent.
It's just until the junction. And what I do now, because I'm happy, I do like this. I take this out, kommen Sie hier komprimieren?
Yeah.
Yes, I do. And I compress here, like very relaxed. I stand and talking to the patient and put my body weight, body weight on the, I come down so you see me, body weight on the leg, just to make sure there will be no reflux into the just formed area. And I was very impressed to see that there was really little foam in the common femoral vein. Normally, if you do the sclerotherapy, you see a lot of it. And this is because I used 3%. I stopped injecting when I saw it was there. And the vessels were really contracted by the adrenaline.
Excellent.
So this is, yes.
Excellent. So what is your trick with the ice bag, Joseph?
Ice acts as an analgesic. It acts as a vasoconstrictor, and it also we also use it for compression. So you can see where Dr. Erica's hand is in the groin. I've got these nice flat cubes of ice, which I use to just gently compress. So you get hypothermia, which basically vasoconstricts. It acts as an analgesic. The patients love it because it makes the place feel good, because immediately post-injection, you know, you're getting your hyperemia and your rubor and the dolor and so on and so forth. So, you know, they're just little things that do assist. And of course, the best way to minimize bruising and bleeding is to use a simple ice and cold pack. So it's a little additional item which really makes a huge difference. I've been using it for years, and I love it.
It's a collection of fine tips and tricks that will get you
precisely. Yeah, and as you can see, Professor Dr. Erica has really demonstrated a first-class approach to quite a large aneurysmally dilated venous almost malformation. In simple terms, establish secure
compression short. You can buy them in the bitte Kopf unten lassen. Bitte Kopf unten lassen. Patient shouldn't elevate the head because he's doing muscle contraction until everything is inside. And can we put the second mobile just just to look. Muss jetzt gar nicht so, aber einfach, dass Sie das Bein sehen. We put compression in the first to the leg, then we put didn't keep the name with me. We put this things in the groin just to extra compress, and he gets a short trouser on it. And as to my experience, I'm doing this with the trouser, with the extra trouser when I treat the groin since the year before COVID, so 19.
Yep.
And my experience is that the results are better when I do recurrent varicose veins in the groin, which this looks like really. So we have the stocking until this point, the highest as possible. We put extra bandages there, fixed by the trouser, by the yes, and then we put the other one on top. And I think that this could help keeping the things closed. And you see, even if everything is being performed, the patient at least is 5 to 10 minutes recumbent before he gets up.
Yep.
And sometimes I say something in German, say Kopf runter, put your head down, because if you put the head up, you really press with the stomach muscles and you put the blood back to the leg. Okay, so sorry for interrupting, but I had to
no interruption at all. I have really to congratulate you, Erika. It's amazing, because in the beginning of my career, this patient would have been a typical patient for varicose vein surgery with a procedure that usually will lose 2 units of blood, and he will stay with us in the hospital for 3 to 4 days. And the complication of post-operative hematoma, and today I've seen amazing things, really. It's like magic, Erika.
Okay, thank you so much.
No, it's true.
I see a very interesting question there from Baha Rifai.
Yes.
How many days would you wait? This is a really good question. For the dosage I am allowed to apply, it's 24 hours, because you can apply 10 mils of air in 24 hours. But I normally let the tissue react and wait 1 week for the next session. This is in normal varicose veins. In these transtibial varicose veins, yes, I do it every second day, because there is no tissue. I have to really close the point. And when I used to do it with weeks in between, the results were worse. So I will see the guy on Monday and on Tuesday, if necessary, just to redo it. But this is the transtibial perforating vein, which is a completely different approach. In normal situation, I wait 1 to 3 weeks. I often do it like I do the second look and treatment when they come back for the control of the hyperpigmentation. Yes? Okay.
Yeah. Fantastic. So a lot of comment congratulate you, Erika, about the great demonstration of 3 of the most difficult cases, and to congratulate Joseph for very nice technical tips and tricks. So
and I thank him, because I learned this thing from him.
Yes.
I learned the blunt needles from him, which seems to be a stupid thing, but it's very important. And I learned the adrenaline, which really made change in my treatment of the patients.
Yeah. You know, when we get puncture in United Kingdom, accidental puncture by needle, we have to fill what is called puncture form. And with puncture form, it takes about 30 minutes to fill it up. And they take blood sample to see what is our virology situation. So to save this step is like saving for you 1 hour and puncture. So this is very good. So I know we're nearly reaching 2 hours. It was really fascinating. I would like to invite you, Erika, to conclude and give us your summary, your experience, and Joseph. And at the end, I would like to thank MOH. So back to you, Erika, to summarize fascinating day.
Thank you, Mohammed, because you're always a real fantastic commenter and organizer of the session. Thank you so much. I enjoyed it as always. Thanks, Joseph, for not only having been my teacher in this part of treatment, but for the very good comments. And I can only recommend everybody to visit him in Sydney, because I have never seen, I think I'm good organized in my office, but I've never seen such a good setup also for teaching, because he films everything. He has 2 ultrasound images. He has a complete room. He has everything. It is gorgeous. So if you find the time and happen to pass by Australia, which is just around the corner, you should stop by at Joseph's place and learn there. And I'm very thankful to MOH and Sigvaris, because they opened the doors to this hand-on workshops. And I think the results this year have been so good that we will go on with them next year. We have still one in November. I think it's the 21st. I don't know exactly, where we will show compression in case of ulceration of legs, how to compress the legs in people with ulceration, and how to make a punch needle punches and put skin on the skin, on the ulcered skin. I'm sorry, my English is gone today.
That's all right.
By
Sponge graft.
Wonderful Spanish sponge grafts, yes. A wonderful Spanish colleague. I will just come back when Joseph has finished. I tell you the date and the hour exactly. So Joseph, the mic is yours.
Yeah.
Oh, well, it's a good evening from me here. It's midnight. I've got to say, this is my first Medical Online Hub experience. So I want to take this opportunity to thank, obviously, Mahmoud El Gadban for the invitation. I want to thank you for your kind moderation and control, Professor Omar. But more importantly, Erica, I would like to share with the world and my colleagues here that you are truly a beacon of hope and inspiration, and a first-class educator and teacher. And this is very, very evident here today. I have learned so much from you, and this is what it is. This is what it's all about with collegiate sharing and so on and so forth. The invitation is always open to visit us here in Sydney, Australia. I would be delighted and honoured, to say the least. I love my work, and I'm very passionate about what we do. And sure, we're always students. And thank you for your very kind invitation, Erica.
Thank you.
Okay.
Thank you so much. I am November the 6th. Wow. 4 p.m. Wednesday, November the 6th. It is with Elena Conde from Spain. And this will be very interesting, because it is an easy to do, cheap to do skin transplant. And I will talk about the possibilities to do compression on ulcerated skin, which always with a regular stocking is not as easy, but there are lots of solutions. So thank you very much to everybody. And Omar, Mohammed,
Okay.
the mic is yours. Thank you.
Okay, so I would like to thank everyone. I would like to thank Dr. Mahmoud Al Ghadban. We are fortunate that he was unable to be with us today, but he sent all his best wishes to us. I enjoyed thoroughly every femtosecond with Erica Mendoza. And I really enjoyed the wisdom of Joseph. And I think the platform of MOH is fantastic, because it is clinical, it's applicable. You can use it the second day. We show you direct relation of management to the patient straight away. And this could never be beaten by any lecture, any textbook, or any congress. So I really like the idea of Medical Online Hub. I'm very thankful to Sigvaris and our dear organizer, Prime, for his excellent audiovisual and his excellent effort. Thank you very much. We hope to see you again, and wish you all the best.